This is N&I Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Andrew Prentice and Tanis Fenton share their knowledge and insights on normal growth, principles, practicalities, and pitfalls of growth assessments in infants and children.
Welcome to our podcast, N&I Bites Big Learnings. My name is Andrew Prentice, and it's my huge pleasure today to welcome Dr. Tanis Fenton for our podcast. Dr. Fenton works at the Department of Community and Health Sciences at the University of Calgary in Canada. She's a registered dietitian and an epidemiologist, and she's famous for having developed the Fenton preterm growth charts based on what she saw at the time as a need when working as a dietitian within a neonatal intensive care unit. These growth charts are used internationally. Dr. Fenton was the invited chair for the Preterm Infant Expert Working Group for the American Dietary Guidelines for Preterm Infants, and her research interests include nutrition, premature infant growth, and knowledge translation, of which she's really passionate. Today, we're discussing her paper on what is normal growth, principles, practicalities, and pitfalls of growth assessments in infants and children. And this appeared in our latest edition of Annales Nestlé. Dr. Fenton, welcome to the podcast. It's really great to have you here.
Thank you, Dr. Prentice. I'm grateful for this opportunity.
Now, your paper is part of a series on the importance of assessing growth in infants and young children, and we're focusing our efforts here on helping to inform healthcare professionals. Perhaps we might start by reminding our listeners, I imagine many of them will know it, but even myself, I get confused sometimes, reminding them about the distinction between growth reference curves and growth standards, and how the WHO growth standards were derived.
Yes, this is an important point. The key difference is about whether healthy populations were selected to represent the growth. For the WHO growth standards, they selected healthy children from communities around the world where economics would not likely constrain growth. In comparison, many growth charts are growth references, since they just represent samples or populations that did not exclude children that had health or economic situations that could have altered their growth.
And what was remarkable about the WHO study was that across disparate countries from Ghana and America and so forth, when they did select, as you've just said, populations that had no constraints on the infant growth, then they were all remarkably similar. And that really was the basis of developing the standards. How should we define stunting and wasting?
I think the WHO's definitions are useful. They define that children have stunting if their heights are shorter than 2 standard deviations below the median or the middle of the growth chart, which is between the 2nd and 3rd percentiles. And they use the same cutoff point for wasting using weight for length or body mass index when they are less than 2 standard deviations below the median. And it's important to use weight for length or body mass index to assess for wasting because they take height into account. Weight for age alone isn't very helpful because children vary in their heights, so they should vary in their weights. So weight for length or body mass index are very useful for children for that reason.
Absolutely, and we'll come back to the issue of height and what determines that in a short while. In your paper, you make a really important distinction about the use of growth standards for population assessments as opposed to individual patients. And of course, here, for health professionals, we're talking about individual patients, really. And what you do is you raise the issue, which you've kind of just mentioned, that because we use a cutoff of 2 standard deviations, then by statistical inference, about 2.5% of perfectly normal children would be accidentally misclassified. So perhaps you could explain that a little bit more to our listeners.
Yes, an important point for sure. It helps to understand 2 things. First, that the cut points, as you mentioned, are statistical cut points. So they didn't take some children and say, you're unhealthy and you're in the tails. Rather, they used the bell curve and they used cut points that are defined simply by statistics. And the other important point is that the World Health Organization growth standard was based on healthy children. And as mentioned already, they were healthy children selected from communities that didn't have economic concerns that would interfere with their growth. So applying their criteria that we just talked about to their own growth study infants, one would consider that 2.3% of these carefully selected and healthy and non-economically disadvantaged children would have stunting, wasting, or overweight, but we know they're healthy. So these were healthy children, and those in the tails of the distribution were healthy and appropriately sized for their own individual growth potential. But yet they would be defined as having stunting, wasting, and overweight by their own criteria, so that they would be misclassified. If you had a group that included some unhealthy children, as we do in the world and in clinical practice, we would expect some of them would fall into the stunted, wasted, and overweight categories. So that's really where we have the challenge, to differentiate between the healthy and the less healthy children in the groups that are beyond 2 standard deviations, because some of them will be healthy. I think the WHO emphasizes and encourages the use of them so that people can identify if their population has excess of children in those categories, because then things need to be changed in that population. I think that's why they emphasize them so much. And I would like if they would add some cautions about using them for individuals.
The history of the derivation of the WHO cutoffs, it's a bit complicated, and there's a problem at the 5-year boundary. Can you delve into that for us a little bit?
Yes, so the WHO used their own growth reference study to develop their growth standard that goes up to 5 years. And then for children aged 5 to 19, they have growth reference curves, but they looked across the world for the best data that they could find. They didn't derive the data by selecting healthy individuals in healthy countries. Rather, they looked for data. So they had more confidence in their data for children under age 5. And then they set different cut points for overweight for children under age 5 versus children and adolescents that are older than 5 years. And I think they almost should have used the criterion in the opposite direction than what they've done. For under 5 years, I agree with what they did. They set greater than 2 standard deviations above the median for weight for length or body mass index is overweight. I think that is an appropriate line to draw for the population. Then for children and adolescents 5 to 19 years, where they had less confidence in the data, they set the cut point for overweight at +1 standard deviation. So the criteria change at 5 years. And of real importance, they point out in a 2010 publication the reasons for their caution about deciding about overweight for individuals under age 5. And I think these actually apply for all ages. First, they considered that the children are still growing. Second, they admitted that there's few data on the functional significance of the cutoffs at the upper end of body mass index for age distributions in healthy populations. And third, another reason to be cautious is to avoid the risk of putting children on restrictive diets. And further to that point, I just became aware this week of 2 new 2024 Cochrane reviews that looked at the evidence about whether interventions to change children's diets are effective at changing their weight status. And these were led by Francesca Spiga. Very well done systematic reviews. And they found that interventions that included diet and physical activity may have a modest beneficial effect on overweight, but we lack evidence that changing the diet alone will change a child's weight status. And so I think we need to be careful about telling people they're overweight, especially if they're just +1 standard deviation.
Let's talk about the range between a healthy child to a patient who's not growing well.
Yes.
Give us some advice about what should healthcare professionals keep in mind about, what are the primary determinants of how a child grows?
Yes. The primary determinant of how a child grows is their genetics, especially for height alone. And there are many diet practices around the world that support children to grow to their genetic potential. And as we all know, both illnesses and lifestyle can influence growth. Body proportions and weight are influenced by genetics as well as lifestyle to some extent. And in this era where advertising really influences choices, particularly around food, body proportions may be more influenced than in past eras. The range of genetic potentials can be seen on growth charts by the spread of the growth curves. So, sometimes people think, oh, a child should measure on the 50th percentile, but that wouldn't be realistic at all. There is biological variation in size, and growth charts show that variation in size. And we can expect children to have measures anywhere across growth chart curves. A child's genetic potential isn't readily apparent. So it's hard to differentiate, is that child growing to their genetic potential or is there a problem? Parental heights can give us some information, but children can grow based on genetic influences that aren't readily apparent in the parents. You may know a family where the heights of children differ from their parents, and yet that's genetically determined for that child. So for the individual child, once you've ruled out any illnesses or any suboptimal feeding, you get a clue that the child is growing at their genetic potential when you look at their growth patterns over time.
And so the key point is the growth patterns, looking at the growth patterns over time and not taking just a single spot measurement.
Exactly. It is so important to look at the growth patterns over time.
Yeah, and just taking up that little point about mid-parental height, there are many nations in Southeast Asia where actually most kids are growing much taller than their parents. So when you've got populations in transition, that becomes very difficult.
Yeah, so ideally, as we've talked about, you have the child's growth pattern, not just a single measurement. And also, ideally, you have assessed the child's health status and ruled out any medical reasons for poor growth, and also have assessed the family's approach to feeding. Sometimes families try very hard to feed their children in kind of ideal ways. And at our children's hospital, we sometimes have children who are admitted because their parents are trying so hard to keep the diets very ideal that they actually end up limiting the diet. So it's worth reviewing how the family is approaching feeding for their child. And then to be able to judge the child's weight status, we need height measurements as well as weights, so that we can use weight for length or body mass index. And then if the child has always plotted low on their growth charts for weight for length, then it's likely normal for that child to be slim. Now, the further away the child plots from the median or the middle of the chart, you can have more confidence that an intervention might be needed. So I talked about some children, about 2.5% are misclassified. But if you have a child who is very far away from the growth chart curves, then it's more likely that there is actually a problem, which it could be medical, it could be feeding. You need to dig a little deeper to sort that out.
So now, so you were just talking about a slim or a short child. I guess the same is true in the opposite direction. If some child is sort of crossing its centile with accelerated growth.
Yes, that's right. Yeah. Yeah.
So how do we make that judgment?
It can be hard to distinguish. And again, it's very important to have the child's growth pattern on a growth chart. And you can't assess weight status, as I mentioned, without height measurements. And children who are experiencing healthy catch-up growth need to have had their growth suppressed at some point. So catch-up only happens if there was some kind of suppression at some point. And that slower growth can be before birth, from preeclampsia or high blood pressure before birth, or it can happen at any time from an illness. Even a short-term respiratory infection can suppress a child's growth in the short term. And so to be able to distinguish between healthy catch-up growth and accelerated growth, you really need to know the child's history. And then you can feel confident that you are seeing potentially unhealthy accelerated growth if the weight is accelerating faster than height growth, and if they're not recovering from a previous slower growth phase.
Yeah, indeed. In the end, let me end by asking what I know you feel is incredibly important, which is your recommendations for talking to parents about the growth of their children.
Yes, healthcare providers' comments about a child's growth can lead parents to make actually harmful changes to feeding, such as discontinuing breastfeeding early, and then in feeding the child, pressuring or restricting, or even using some products to supplement their child's diet. On the positive side, studies have found that parents really value being reassured that their child is growing well. They're feeding the child every day for months and years, and they really value some assurance that their outcome of their child's growth is good and reassuring. So the best advice about talking with parents about their child's growth is to say at least one positive thing. For example, you could say that the child's growth looks healthy and reassuring. Sometimes there are concerns, and it might be better to say that there's not necessarily a problem, but there's reason for further investigation to rule out problems. And I'd like to say just a few things about feeding children, because I think the feeding relationship has become distorted in modern cultures. And advertising really influences children about their choices to distort the feeding relationship in unhealthy ways. So it's helpful when you're dealing with families to promote responsive feeding, regardless of the child's growth pattern. If they're growing well or if you have a growth concern, responsive feeding still makes sense. So what is responsive feeding? For infants, it's responding to the infant's appetite and satiety cues and feeding on that basis, not on the basis of how much they've eaten. And then for children, responsive feeding assigns the parent the responsibility to decide what foods, when, and where are offered to the child. And the child's responsibility is to decide how much to eat. They're the ones that have the knowledge of hunger and satiety. So it's best to give children that responsibility.
Thank you so much, Dr. Fenton. You've walked us through this really complex area so clearly and helpfully, and based on a lifetime of research as a dietitian at the front end. So really, really appreciate it. Now, as we traditionally do in these podcasts, let me end by summarizing your key messages. We start with a reminder that normal growth is assessed differently in populations versus individuals. Normal growth for populations has been defined by WHO as a height better than -2 Z-scores and a weight for length within plus or minus 2 Z-scores. Remembering that some children will inevitably be misattributed, about 2.5% or so. So using population criteria for normal growth for individuals is not appropriate. Growth patterns of individuals represent a combination of their genetic potential interacting with environmental influences. And it's challenging to decide for any individual patient, any individual child, whether their growth pattern is appropriate for that genetic potential, or whether it's unduly influenced by illnesses and environmental factors or disease. So, as healthcare professionals, your clinical insight based on your experience is really, really important. And I'm going to invite Dr. Fenton to come back with the last point, which she feels really, really passionate about in terms of talking to parents.
Yes. Thank you, Dr. Prentice. So about families, when healthcare providers are talking in their conversations about growth and size and weight, it's so important to do this in a responsive and non-blaming way so that the parents can feel supported and empowered to take the actions that you are recommending.
That's a wonderful place for us to end. Thank you again, and thank you, listeners, for following our podcast. And we hope very much that you'll subscribe through the NNI 365 app so that you ensure you don't miss our future offerings.
And that concludes today's episode. Thank you for joining us with Andrew Prentice and Tanis Fenton as we talked about normal growth, principles, practicalities, and pitfalls of growth assessments in infants and children. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.